All right, what's up? Good morning, everybody. Good to see everybody on this Thursday. So I'm actually back in clinic. I am back in Michigan in the physical therapy clinic that my brother and I ran for a bunch of years. That would have been about circa 2013-ish. No, 2011-ish through 2014-15. So good to be back here. Good to be back with the team. Seeing a lot of patients and scraping up a lot of good memories. It's been fun to be back. So anyhow, huge thanks to everybody. Hey, what's up, Kelsey? Good morning. Huge thanks to everybody who downloaded the cervical risk PDF over the past day or so. A massive amount of downloads. It's been wonderful to keep this conversation going about cervical manipulation safety. And the idea of that PDF was just to give a lot of you who haven't really taken that deep dive into the literature, maybe a bit of a roadmap of key articles across key topics and areas that really facilitate that deeper understanding that allows you to be comfortable or more comfortable in this nuanced area. That is very important. Great feedback from the PDF, but a lot of the dialogue coming back at me yesterday via email, via text, etc., was still revolving around some things that we need to move beyond. So really appreciated the overall quantity of dialogue, but still some recurring themes that really don't belong in the place that they currently are in the dialogue. They don't deserve as much attention as we're giving them. So let's talk about those and see if we can bring those to light and maybe help to move beyond those into some of the other nuances that really are important to continue discussing. So the first one is that the risk of cervical artery dissection, right, vertebral or internal carotid, is not a thrust manipulation thing. Right, and so even though we're having the discussion surrounding thrust manipulation, right, this is not a thrust manipulation thing. It is a neck positioning thing, right? So the concern is that somebody either under your care or in their own daily life positions their neck at a given end range, right, specifically rotation or extension, and that places a mechanical challenge upon the cervical artery, right, that may cause compromise, right, mechanical failure or dissection. So think about when you're taking your history with your patient, right, and you're curious if maybe there was some minor mechanical trauma that may have caused a dissection that is now causing a vascular pain presentation, and you're trying to think about, risk benefit on this and do I need to make a referral? Realize you're not just asking, did you have thrust manipulation in the past week, in the past month? You're asking, did you do anything to your head and neck that may have caused possible compromise to one of the arteries of the cervical spine? That's what you're asking, right? So you should be asking, right? Did you have any falls? Did you have any significant jarring events, right? Did you have any weird neck positionings? Did you paint your ceiling and hold end range extension for 3 hours? Did you do anything at all where in your life where you placed your neck at an end range position that may have caused mechanical challenge to one of the cervical vessels? Right? And the concern is if it did, that might be generating a non-ischemic vascular pain presentation that looks a whole lot like a musculoskeletal neck cervicogenic headache, one of those kind of presentations, right? But realize you're not just asking, hey, have you had cervical thrust manipulation in the past couple weeks? You are asking, did you place your neck? Did you do anything that put your neck into one of these positions that may have caused that compromise? Well, then your clinical behavior should mimic that. Right? So that means that if you for whatever reason, right, really want to be cautious with an individual's cervical spine and not place their neck in a position that causes any mechanical strain to the cervical vessels, that won't entail just withholding thrust manipulation. That will entail not putting their cervical spine, their head and neck in end range positions that cause that mechanical strain. Right? So yes, that would certainly include avoiding thrust manipulative procedures that don't have secondary levers that approach one of those end ranges and possibly cause that compromise. But it also includes anything else that would put their neck in one of those positions that could cause that compromise. For example, right, taking someone and having them do snag rotations, right, taking someone's neck who has decent mobility, putting them in this position and doing end range cervical rotation snags. Right? That would put their head and neck in one of those positions. Having somebody lying prone, maybe they have low irritability and you want to do some medial incline PA or lateral glide mobilizations. So you put somebody in prone and you have them lay on your treatment table in end range rotation, and now you're above them doing a medial bias PA or lateral glide. While they are in end range cervical rotation, you're doing an oscillatory mobilization. That would be considered putting someone's neck in an end range position that can cause mechanical strain to the vessel, right? So the point is, it's not a thrust manipulation thing. It is a head and neck positioning thing, right? And we look at it that way in the history. We need to be looking at it that way in the clinic, right? So you don't all of a sudden become safe because you're not doing thrust manipulation. You become safe when you realize that the way you handle that person's head and neck needs to be in mid-range position across all cardinal planes of movement. Right, so you're not going to do anything, thrust or mobilization or exercise, that goes to end range rotation or end range extension. You're not going to give out a home program that encourages the head and neck into one of those positions. So we need to really, really get beyond the fact that this is all about thrust manipulation and realize that this is about avoiding positions of the head and neck that can cause mechanical strain to the cervical vessels. One of those things could be poorly performed cervical thrust manipulation. Many others exist, and your awareness of that being the pivotal issue is what's going to help you manage these folks safely. So that's a really, really important one. We got to move this beyond it being a cervical thrust thing and move it towards a conversation about head and neck positioning across all paradigms. Okay? The number 2 one, and this bugger's been pervasive, and I totally understand. Hey, Liz, does the referring provider need to... reading a question from our friend Liz Pepin. Hey Liz, I'm actually very close to you right now down on Iron Mountain. I was in your neck of the woods jumping off Black Rocks into freezing cold Lake Superior a few days ago. Does the referring provider need to give you guys any specific information to help identify these patients at risk? So Liz, that answer is a long one. So does the referring provider need to give information? I think that certainly there should be good dialogue amongst everybody if that person presents in a way that indicates it could be vascular referral, right? So it could be a non-ischemic vascular pain presentation, ipsilateral neck pain and headache, certainly any signs of lower cranial nerve dysfunction, any optic issues, any numbness, tingling, paresthesia up in the head and face, right? Any of those things that correlate with possible vascular presentation, we should all, as a team of providers, be on the same page in doing a really diligent history in looking at whether or not there was minor mechanical trauma, right, that may have caused vascular compromise. So certainly, Liz, I think that referring providers back and forth between each other, we all need to have an acute eye looking at that history and saying, was there a chance that those tissues were compromised and thus could be generating that pattern? So absolutely, good communication is key. Liz, I will call you next time we get up there. All right, number two, and again, pervasive and understandable, is that atherosclerotic risk factors are a key variable, right? So it totally makes sense. And part of the reason it makes sense is in some of the earlier literature, this was focused on. So you can appreciate that if your concern is somebody's cervical vessels failing, right, or becoming compromised, you would think that it would behoove the provider to get a really good understanding of the overall health of that cardiovascular system, right? Because if you're concerned about challenging vessels and the vessels not being healthy and failing, an overall idea of the health of the individual's cardiovascular system should be in order. And you would think that would parallel or help you predict who might be at risk for catastrophic event following manual therapy. The surprising thing is it doesn't. So what we consistently see is that atherosclerotic risk factors do not seem to be of use in predicting who is going to have a catastrophic event following manual therapy. Now, that does not mean, right, that it's not important to gather atherosclerotic risk factors. That does not mean that atherosclerotic risk factors are important in considering someone who's at risk of stroke for reasons that are non-dissection oriented. But speaking very specifically of somebody having a catastrophic event following cervical or head and neck positioning in manual therapy, it does not seem to be strong utility. So we're seeing over and over again in the recent literature that is the case. In fact, and I'll admit that I put this on Twitter a little bit just to try to steer the conversation way in the other direction, but the most recent paper by Carey and colleagues showed that there was actually a slight protective value of having atherosclerotic risk factors on board. Now, no one's saying that you should go out there and try to increase your atherosclerotic risk factors so you can increase your safety receiving cervical manipulation. But it's interesting that not only was it not found to be a predictor, but it was almost found to be protective. Now, unfortunately, and I felt bad for Kyle Kimbrell because he kept trying to keep the conversation on task. But inevitably, anytime you tweet something like that, the conversation spirals into should we be doing cervical manipulation, which is fine, but it kind of got away from the point of the convo. And what Kyle kept saying was, does anybody have any idea why that it shows up that atherosclerotic risk factors could possibly be protective of cervical dissection? Because it makes very little sense. Kyle, to answer your question, because I know it was killing you in that thread, I don't know. But my intuition or my 2 cents would be that atherosclerotic risk factors tend to come along with individuals who are older and, quite honestly, are generally kind of unhealthy and lack mobility. Well, those aren't your riskiest patients for cervical dissection following manual therapy simply because you can't get their neck. They don't have enough mobility left for you to get their head and neck in the kind of positions that challenge the vascular system mechanically. Right? They're so stiff in their neck that you can't take up all of the vascular slack because their head and neck won't allow you to because they're older, they're stiffer, they're less healthy. Remember, our biggest concern is younger individuals, right? Sub 40 individuals who have decent mobility. Why? Because those are the heads and necks that you can actually take all the way to end range to a position where you take up the slack of the vascular system and can place a challenge upon that. So I think the reason we don't see the atherosclerotic factors paralleling dissection risk is because individuals who have them tend to be old and stiff. And in those older, stiffer people, they don't have enough mobility for you to get their head and neck in a position that causes actual mechanical strain onto the cervical vessels. That's my thought. I don't have any proof of that, but Kyle, I just know it was killing you in the thread, so I want to drop that here for you. That's why I think that parallel might exist. But the point I really want to make here is that atherosclerotic risk factors, that profile, does not seem to have utility in predicting who may have a catastrophic event following cervical manual therapy. So while it seems intuitive and while it seems logical, that doesn't seem to have a lot of value here. So I think that what we don't want to see is a false sense of confidence where people are like, hey, this person has like a super healthy cardiovascular system. I'm going to be able to challenge it and we're going to be fine. That is the exact thing we don't want you to do. Right? Because it's not evidence-based, first of all, and it's going to give you a little bit, I think, of false bravado in taking people who are young and healthy, who are actually the people that oftentimes we're worried about because they have good mobility, and taking them into end-range positions there and challenging them. It's going to give you a false sense of confidence when it shouldn't. Okay, so think about that. And again, if you downloaded that PDF, I gave you a lot of really good articles that dive into this stuff in detail. So dive back into that document and have a look at it. All right. Last one, right? And this one really does probably need to start going away. And that is that positional testing is useful, right? So again, those of you who downloaded the document, you probably read a lot of the articles already. And one thing that we're seeing is an increase in confidence that positional testing lacks diagnostic utility. Right. And I mean, Roger Carey's been saying that for over a decade. Right. But we're seeing with more and more increased confidence. And I think you're going to see some articles coming down the pipeline over the next year that say it even stronger, that positional testing simply doesn't have diagnostic utility. Right. Putting somebody, the VBI test of kind of bending somebody over the back of the table and rotating and extending and side bending does not seem to have diagnostic utility in predicting who is going to have a catastrophic event following cervical manual therapy. And here's the problem, folks. If we can all accept that that doesn't have diagnostic utility, right? And the real reality is it's probably not even testing what you think it's testing, because when you look at like Lucy Thomas's work, when we see that when someone goes to end range rotation, right, there is increased challenge to the contralateral cervical vessels, right? So we see that there's mechanical challenge there. But what we don't see is a decrease in total cerebral perfusion, right? So we don't see a decrease in the amount of blood getting to the brain. Why? Because the ipsilateral vessels compensate. So if you think that when you get somebody in one of these positions that you're testing the vessels that you're straining, the reality might be you're actually testing the ipsilateral vessels that aren't being mechanically challenged, their ability to compensate, right, and to keep total cerebral perfusion equal. So we're probably not even testing what we think we're testing, right? But what we see is that doing that test does not provide good diagnostic utility. And the challenge I want to make here is that it is doing the thing, right, that we aren't going to do in practice. So it's doing the thing that we're intentionally avoiding. So when somebody comes in, if we are concerned about the overall robustness or of their cervical vessels, the one thing that we are going to avoid, again, going back to point number one, not only during our thrust manipulation or hands-on care, but during their home exercise program, during their ADLs, right, is going to be end range cervical positioning. Well, those tests require end range cervical positioning, right? So you're doing the thing that you know you don't want to do, right? So you're putting them in a position that mechanically challenges the vessels that you don't want to mechanically challenge. And the problem is now you're doing the thing you don't want to do, and the information that you're getting isn't useful in you moving forward in your clinical reasoning. So it's really a lose-lose because you're taking them back and challenging something you're concerned about, and you're not getting good information. So we've got to get to a point now where we sort of accept that those positional tests, right, don't seem to have diagnostic utility, and yet they are placing challenge on vessels that our clinical reasoning suggests should not have challenge placed upon them. So you're doing something to a patient that isn't giving you good diagnostic information, so that you can do a technique that's nowhere near as aggressive to the structure you're concerned about as the test that you just did that wasn't diagnostically useful. That doesn't make a lot of sense, right? And so we all as a group probably need to accept the fact that the utility simply isn't there for those tests, and move into the history and move into all of the issues, looking at trauma, looking at balance, looking at paresthesia, looking at cranial nerves, looking at optics, and doing the things that carry a lot more value in knowing whether or not someone is safe to be moving their head and neck around, for them to be moving their head and neck around, for them to be doing certain activities where their neck is placed in certain positions, and really have more of a robust reasoning and more of an evidence-based projection. So those are three big ones that I got. Again, thanks for the downloads of the PDF. Thanks for reading that research, and thanks for taking the time to be willing to not just read the surface level, but grab those articles and dive in and challenge your biases and come back to the table and really deepen this conversation, so that when you have somebody under your care, you have a much wider and broader overall understanding of the breadth of research, so that you can operate in a way that is much more evidence informed inside of your reasoning. So three things. Number one, it's not a thrust manipulation thing. Right? It's a head and neck positioning thing. When someone comes in their history, we are not asking them, did you have thrust manipulation? We are saying, have you had your neck and head placed in end range positionings that really initiated this unique pain pattern that you have? And the reason we're asking that is we're concerned that the vessels got challenged. But it's not just about thrust in the history, so it shouldn't be just about thrust under your care. It's about all head and neck positioning. Number two, atherosclerotic risk factors don't seem to have a lot of value in predicting dissection following manual therapy, exercise, etc. They have plenty of value in a greater clinical reasoning model, but in that area they don't seem to. Number three, positional tests don't seem to be diagnostically useful, and they are causing you to place your patient's head and neck in that position that you're intentionally going to avoid with everything else you do. So why would you do it during your testing? Those things are big. Let's move past those and keep diving deeper into everything we can do to be safe in this area. So thanks again. If you haven't downloaded the PDF, I will put that link underneath this video. Basically, what we did was went through a lot of the key areas that require an extensive knowledge to carry out safe practice, and gave you all abstracts and a few highlights so you can jump in, download those articles, read that information, and really become well explored and well read in this area. Thanks, everybody. Have an awesome time on the rest of your Thursday. Got some great classes coming up. Dunaway is going to be in Marietta, Georgia, doing total spine thrust manipulation. I'll be in Munster, Indiana here coming up for cervical spine. A lot of good stuff coming up. Older adult, I know next coming up there, next cohort for the online course starts up. So all sorts of good stuff. Hey, many of you were on for Rising Tide Q&A last night. That was awesome. So if you're going to be joining us in Albuquerque and you want the recording of that Q&A last night, we all talked about the event, let me know. I'll shoot it over to you. Otherwise, get out of here. Have an awesome day, team.